is a significant outcome which needs to be measured in diabetic patients, because of we see there is thing called as clinical inertia, in which we try to initiate the patient on single drug, and when the drug is not effective, then we add another drug. This is basically the clinical inertia, and because of the inertia there occurs treatment failure. So it has been suggested by the guidelines also that if the glycemic control is not good at the baseline, so that means if the HbA1c is more than 8% and in some guidelines more than 7.5%, then we should initiate with the combination therapy from the very beginning. And this thing only was reinforced by the Verify study, which showed that early initiation with the combination of metformin and vildagliptin, it has a better efficacy, as well as the time to treatment failure is also prolonged in the combination therapy group rather than the metformin monotherapy group. And in the subgroup analysis, they also assessed about the cardiovascular outcomes in these patients. And this study suggested that this drug, if not cardioprotective, this drug is at least cardio-safe. So though it was not a CVOT or a cardiovascular outcome trial, it was just an efficacy trial. But this study showed that vildagliptin is quite an efficacious drug when combined with metformin. Secondly, it prolongs the time to treatment failure as compared to the metformin monotherapy alone. Thirdly, this drug is at least cardio safe, and if not cardioprotective, this drug is cardio safe.
Thank you, Arpit. One thing which needs to be taken into consideration regarding this drug is that we do need certain parameters and evaluation before starting this drug.
Right. That's perfectly right.
Heart failure, like we need an echocardiography definitely to look for the LA size before we are going ahead.
Yeah, echocardiogram we need for the liver functions also we should assess, because vildagliptin is one which can be deteriorate the liver function tests in a patient who is already having compromised liver.
Dr. Rakesh, what is your say on combinations and vildagliptin? You need to unmute yourself.
I think for last 10 years, we people have this vildagliptin with us now, and we have used all the combinations whatsoever we can imagine. Basically, we initially used to have metformin with sulfonylureas. Now starting with the metformin as a monotherapy, combining with the metformin. Even somebody comes to us with the double drug metformin sulfonylurea combinations commonly comes to us in the OPD, and we use vildagliptin to a good effect, to a very good effect. Then people are already taking triple drug combinations, then adding on to those. Even then it's effective, although it's said that the efficacy of the drugs don't go beyond triple drug combination. Even then we have seen in our day-to-day routine OPD, once somebody is on triple drug, very commonly patients comes to us with drugs on triple combinations, and we add vildagliptin. It's quite efficacious. Not only this, combining vildagliptin with metformin, patients on insulin, one is able to have a much better control as compared to alone on metformin with insulin. So this is the one which I can say that very commonly we get our patients from specially old practice, from you can say ECHS or something like. There are some standard protocols are there that you need to give insulin along with the metformin, and they come to us with the deteriorated sugar levels. Once we add vildagliptin or for that sake any DP4 inhibitors, one is able to have a much better control, or one is able to decrease the doses of the insulin. So as far as combination part is concerned, now coming to SGLT2 inhibitors also, it's such a wonderful combination of SGLT2 inhibitors with the DP4 inhibitors, whether vildagliptin or any drug. It's really efficacious drug and complement each other's action. That's the most important part, especially combining metformin with SGLT2 inhibitors, with DP4 inhibitors. Not only is very effective combination without compromising, without having much of a hypoglycemia, and then complementing each other's action, and if need be adding insulin. It's really good drug to be combined at any stage of the disease. I think it's a good drug to be added, even at the, you can say, old duration of the long duration of the diabetes is there.
Dr. Raghavendra, what do you feel regarding this combination therapy in the subset of our renal patients who are coming in?
In initial stages of renal disease, GFR is more than 40, 50, we can use any combination, like Dr. Goel said. And we have tried and we have experimented with all these, all oral hypoglycemic agents which are available in different combinations in the market. And no doubt this vildagliptin has come up very good. All DPP-4 inhibitors and SGLT2, especially with the additional renoprotective actions. So we have used it recently in the recent year times, and we have found that these two group of medicines, they are very effective and very useful in the clinical practice. And some DPP-4 and some SGLT2 we can use, as we know, the aim is to control the sugar. Like in the era of hypertension also
In era of diabetes.
I'm sorry.
Yeah, we can hear
You know, diabetes, control of blood pressure is more important, most important, and control of sugar is also most important. The control of these two things, causative factors, which are preventing complications and preventing disease itself. So no doubt, insulin is the best. The combination of insulin with short or long acting, or with the different types of insulins available. But if insulin is not able to control, and we use in renal diseases, and we use this DPP-4, in mild to moderate, we can safely use. But in end stage renal disease, it is we have to see to the doses, and the adjustment of the doses is required. Excuse me.
Dr. Jeevan, if we look to the post-patient era, how will you place, what do you think the role of vildagliptin, especially as a DPP-4? How can our patients go about with that?
In the present scenario?
Yeah.
There was, as we know, this vildagliptin, say DPP-4 inhibitor, especially the vildagliptin, has very good control of the sugar levels. As we first patient comes to us, or the endocrinologist, I think there's a very good choice of adding this, starting with the medication with the vildagliptin along with the metformin, and after that we can, if there's sugar levels are not controlled, then we can add upon the other drugs. And most of the patients have very good control on this combination of drugs of vildagliptin and metformin. And we can use in the renal failure also with some dose modification is there. And in cardiac patients, it is although it's not cardioprotective, the studies doesn't have show the cardio, but it's a cardio safe drug we can use in the cardiac patients also. Only thing is the hepatic failure, with a severe hepatic failure, where this drug cannot be used in severe hepatic failure. Otherwise, I think it's a very good choice. And nowadays, in cardiac patients, SGLT2 inhibitor like dapagliflozin is also a very good choice to use with as a protective for the heart failure patients. We can use with the diabetic or non-diabetic patients also.
Yeah, I'll like to ask one question common to all our panelists looking to the COVID era. Your views on treatment of a COVID patient with DPP-4 and SGLT2. What will be your say on this combination for the audience? I'll start with Dr. Arpit, and then I'd like everybody to give their views, because this is very important nowadays. Like in COVID times, we are having teleconsultation and we are having patients coming in with COVID. What is your take on point of DPP-4 and SGLT2?
Right. So, so this is a very good question, because this is COVID is the main thing which is bothering all the physicians, I think, as of now. And as far as the diabetes management is concerned in the COVID patients, I think DPP-4 inhibitors are fairly safe drugs, because these drugs do not cause hypoglycemia. These drugs do not have any adverse effect on the appetite also. And I think we can safely use DPP-4 inhibitors, but we have to be cautious about the liver function and the kidney function. If the liver function test and the kidney function is permitting, I think in permitted doses, we can use DPP-4 inhibitors safely in our COVID patients. But I think as far as the SGLT2 inhibitors are concerned, we should be a little cautious with the use of SGLT2 inhibitors, because most of the COVID patients, they are having some loss of appetite, they are having poor oral intake, and in critical illness, any kind of critical illness, there is increased risk of ketosis. And SGLT2 inhibitors per se, they have like a significant adverse effect of euglycemic ketoacidosis. So I think there are a fairly high chances of euglycemic diabetic ketosis if we are using SGLT2 inhibitors in our COVID patients. And secondly, these drugs also cause dehydration. And in COVID patients, there is also already a risk of hypercoagulation, and the risk of clots is already there. And patients have decreased oral intakes. So these two factors, I think, are there, definitely there, which go against the use of SGLT2 inhibitors in COVID patients. But yeah, if a patient is fine, patient is having just a mild fever, patient is taking orally, his oral intake is well maintained, patient is maintaining his hydration, he is able to like communicate normally. In those class of patients, I think we can use DPP-4 inhibitors, but with caution, these SGLT2 inhibitors, but we have to be cautious. We have to tell the patient that these are the adverse effects. And if he experiences any adverse event in the form of like loss of appetite, or if the patient is having some altered sensorium or altered mental status is there, and then immediately I think we should stop the SGLT2 inhibitors in those patients. So yeah, DPP-4 inhibitors are totally safe, but SGLT2 inhibitors have to be used cautiously, I think.
Dr. Rakesh, what is your view about this when you have a patient coming to you post-COVID? He's already treated, he's recovering from COVID. Like, what will you feel about it? Like restarting SGLT2 or stopping SGLT2 or shifting the combinations? You need to unmute yourself.
Dr. Arpit has explained really well that SGLT2 inhibitor is not a very good choice in any acute illness because of the various reasons he has explained in that form. And usually in the acute illness, I personally prefer insulins. Usually no DPP-4 inhibitors, because I personally seen in my practice for last 10 years, whenever there is acute illness, no OHA is very effective drug. No OHA is going to have a very good sugar control, then appetite loss. Any OHA we give, whether metformin, whether vildagliptin, or is going to affect some type of appetite. If somebody is having asymptomatic disease, very mild illness, then definitely one can go with any combinations, including SGLT2 inhibitors, almost asymptomatic disease whatsoever. If somebody is having a stable sugar levels, whatsoever OHA is taking, we can continue with that. But if somebody is having acute illness or the patient requiring steroids, I think insulins are much better choice for any patients we need to give, and especially basal bolus regime. Coming to post COVID, once patient has recovered, I think then also depends upon I personally love insulins. Basically, I use a lot insulins. So I always feel till patient is fully recovered, it's better to keep the patient on insulins, because insulins give good appetite, insulins give good muscle strength, insulin has, we all know, it's a wonderful molecules to be used. If we can teach the patients and we can take away the fear related to insulin from the patient, it's good drug to be given. Because even during recovery also, patients having a loss of appetite, so many muscle pains, so many patients are suffering. Like today only, I have 2 patients which are suffering coming out of COVID, already RT-PCR negative. So I just kept them on insulin only. I conveyed them that I'll keep you on next 15-20 days till you recover fully, then we'll go back to your previous regime. So this is, and most of the times patients develop glucotoxicity also because of patients has taken steroids. Drugs are not effective. Patient sugar levels are already high in spite patient has recovered. Patient's sugar levels with the same drugs, sugar levels are high. So we need to give insulin to these patients. So that's how usually one needs to. And SGLT2 inhibitors are usually little delays the start of the SGLT2 inhibitor in acute illness or recovering from the acute illness.
Dr. Raghavendra, what is your stake in this?
Mild cases, I think we don't, and patient is already on stable and asymptomatic, like, or mild disease. I think we don't need to change the oral hypoglycemic agent if everything is controlled. In moderate to severe, of course, we have to see and watch, and insulin is no doubt is a number one drug, should be number one on the priority basis. And patient detected diabetes came with the COVID and now detected, will not like to start this SGLT2. and DPP. Better to start with the insulin if patient is admitted. Mild case, you can start DPP-4. But in hospitalized patient, it is better to give insulin and control the sugar. And once the patient is on discharge, then we can start DPP. And patient is having mild disease, then we can have ample of choices. We can start anything after the discharge. And post-COVID also the same thing.
Yeah, it was really nice to have a good discussion. I'll be just waiting for some questions coming up. And if there are no questions, then I think so we can end up here.
Yeah, sir, questions as such we have not taken. We will take it back end, sir. Then later on, then we will put forward to you. Then we'll get the answers from you then, because it will take yeah.
So I think so. We have had a good discussion on almost all aspects, right from the verified trial to the combinations, to the kidney disease, to the post-COVID era, to the elderly population. We have almost given a nutshell of everything to everybody.
Yeah, that's really great, sir. Yeah. So just sir, give me some few minutes, sir. Just in addition to this, I have just 2-3 slides to show to you, if you allow me, sir.
Yeah, sure.
Yeah, thank you very much. Is it visible, sir?
Yes.
Yeah, it's visible.
Thank you. Thank you very much. Sir, just would like to introduce, sir, this is first time in the world, once daily vildagliptin from Alkem in the management of diabetes. We have Gluvilda OD, vildagliptin 100 milligrams sustained release tablet for good control in diabetes, ensures glucose control with vildagliptin. Matrix technology is what, we have been doing this. So just 2 points, sir. Mean DPP4 inhibition, that is 85.2% will vildagliptin sustained release versus 86.8% with innovator brand 50 mg BID, and bioequivalent to the innovator brand 50 mg BID, and 84% DPP4 inhibition over 24 hours with vildagliptin sustained release form, at par with the innovator brand 50 mg BID, sir. This is just want to bring into your notice, sir, for which, as you all know, 100 milligram sustained release is being launched everywhere now, sir. So other than this, sir, there is one point, in between. Dr. Rakesh Goyal also mentioned, like in today's scenario, like telemedicine consultation is what, which is being very, taken, very important as such. Just take you through one of the slides, sir. This is Connect to Clinic, sir. I'm sure it is visible to you.
Yes.
Yeah. So this is 100% medico legally, sir, compliant virtual clinic with doctor-patient engagement platform. Well, it is not only a telemedicine consultation, but it is a virtual clinic, sir. And we have, like as I shared, the compliant with latest telemedicine teleconsulting guidelines of NMC, international standard HIPAA high-tech infrastructure, which ensures safety and security, sir. And C2C is another. There is a quick access to consolidated patient history and ensures speedy payment without follow-up. And there is one more point, sir, intuitive and flexible scheduling. Well, you can schedule it as per your preferable timing, sir. And then smart e-prescription and handwritten prescription option is also there. And 24/7 customer care. So these are some of the unique features, sir. And then, as you all know, WhatsApp, Facebook, a lot of things are coming up. So there is a risk of bank account and card details can go into wrong hands, location of data, contacts and pictures, interaction with patient also, patient history also can go to somewhere, and diagnostic logs and device and connection specific information. Just a comparative study, sir, with some of the other, platforms which are there, like Practo, Liberate, Docon, 24/7 Apollo, Doctor One app. If you see, sir, there are some features like service charge. It is 6% with C2C, whereas others 20%, 10%, 10%, like, and 7.5%. Patient counseling support is there, high video quality, high audio quality, which is there with C2C, whereas others, it is not there, sir. Payment within 24 hours, this is one very good option, sir, just to highlight you. Whereas in other cases, there is 7 to 15 days time they take. And complimentary promotion from the company, a lot of like standees, QR codes, and SMS blast, and a lot of features are there which the company is backing up with. And it is not a marketplace, it is your own virtual clinic, sir. This will be your. So just to this is about this. To understand usage of C2C, please get in touch with any of our colleagues, sir, and it would be really great to this, sir. Thank you very much. Sir, just hold on, sir. Yeah. And with this not taking much time, sir, I really thank you once again, sir, especially Dr. Ashish Saxena for moderating the panel discussion so well. And I also, all the panelists, thank you very much, sir, for sharing their views on vildagliptin in clinical practice.
Thank you.
And we'd also like to thank all the doctors who have joined us for panel discussion as delegates, and I'm sure you will appreciate the views on vildagliptin presented today. And we salute our doctors, paramedics who have contributed immensely for keeping us all safe and healthy in these challenging times. And we at Alkem Laboratories, sir, continue to serve doctors and patients by making our product available, especially Gluvilda M, Jupirose, and Allkem. And with this, sir, once again, thank you very much for being a part of this program and giving a valuable time, sir. Thank you.
Thank you.
Nice.
Thank you, Jyoti.
Thank you, Dr. Rakesh, Dr. Jeevan sir. Thank you, Dr. Ashish Saxena sir. Thank you, Arpit
Thank
sir,
you.
and Dr. Raghavendra ji. बहुत बहुत धन्यवाद, sir. Thank you.